Okay, we'll move on. I see our next presenters are online. So we'll hear next from nurse practitioner Brynn Dechert from CS Mott Children's in Ann Arbor, Michigan, about the differences between ICDs and S-ICDs. And then we'll have some practical tips from ARVC patient Julie Carpenter from Colorado, who has had both devices, I understand. So Brynn, welcome. Thank you for being here.
Thank you. Thanks for inviting me. Hi, Julie. How are you?
Great. How are you? Thanks for having me.
I'm going to share my screen here. All right. Can you all see my screen, Marcia?
Yep. Yes.
Great. All right. Cool. As Marcia said, I'm a nurse practitioner at the University of Michigan. I'm specifically in pediatrics, but I do take care of many adults with these types of conditions or other types of conditions that we follow in our practice. I've been a nurse practitioner in electrophysiology for the past 18 years. I think I've actually been part of the SADS board for the last 8. I think I said 6 the last session, but I think it's been 8. And it's been such a wonderful home for me to be part of this important group. So thanks everyone for being here today. All right, so just going through the differences between a traditional ICD, which is a transvenous, or a subcutaneous ICD. I did not today put anything in here about abdominal or epicardial ICDs. We use those pretty rarely. And so I figured that there probably wasn't too many patients out there with this epicardial ICD. Those leads go on the outside of the heart and the generator goes in the belly. But if there's questions about those, I can answer that as well. All right, so moving forward, when we think about the kind of device for each patient, there's several things that we consider. One is the patient size, and this is very important in pediatrics. So with kids, as you know, they grow. So we have to have enough lead slack in order for them to grow tall. And that's a very important part of deciding, how to implant and which type to implant. The second is the actual diagnosis or the reason for the need for the ICD. And I'll go through the differences between the two and why we would pick one versus the other. The third is cosmetic concerns. These devices can be different shapes and sizes, and probably Julie can attest to that. And then lastly, the long-term impacts during the lifetime of a device therapy, and we'll kind of go through that as well. This is actually a picture that I have permission to use of one of our patients who was a collegiate diver. I don't know if you can tell, but as she's diving close to her axilla, she has, or towards her armpit, she has a subcutaneous ICD. She's pretty muscular, so you can't really see that it's there, but it was very important for her to not be able to see this device. And she was able to have a career in diving, even with an ICD. All right, moving forward here. No, it's not letting me move forward. There we go. Okay. So looking at the size of these devices, I picked a Medtronic device. There's no reason I picked Medtronic. I have no conflicts here. I don't work for Medtronic, but I just picked a transvenous device that I know. This is a Medtronic ICD. It's called a Vizia. And then the other picture is of a Boston Scientific subcutaneous ICD. The Boston Scientific ICD goes under the armpit. Usually the Medtronic device or a transvenous device would go up in the left shoulder. You can tell that they're a little bit of a difference in size. The Boston Scientific is bigger and wider this way. But although it has gotten smaller with future or second generations of these devices. All right, so transvenous ICD, the picture on your left is a picture of an X-ray of a person with a transvenous ICD. The can, as I said, sits in the shoulder and the leads go into the vein and into the heart. And so the second picture here shows how that works. So the pulse generator is in the shoulder, like I said, with the vein going in, with the lead going into the vein, and then the tip in contact with the right ventricle of the myocardium. There are many types of ICDs. You may need more than one lead, but this picture is just showing the ventricular lead, which is the shocking lead. This is compared to a subcutaneous ICD. So the picture on the left is actually a scar from a subcutaneous ICD. It's usually in the armpit. The device itself is completely outside of the venous system. So the can is under the skin, but over the muscles and can be under the muscles, but on the left side under the armpit there. And the lead is outside the heart. And that's the important difference between these two types of ICDs. The lead runs up the sternum, past the xiphoid and kind of almost up to the clavicle area in the center. The shock vector goes from that can there, and there's two places that the energy can go to. It can go to that tip, or the secondary, which is the alternate, which is down near the xiphoid area, the center of that X-ray there. So lead placement for subcutaneous ICD is a little bit different. Like I said, here's the can, again, outside the rib cage. The lead is outside the rib cage, and the lead goes from the can and then takes a right-hand turn north here to the top of the sternum. This is another picture showing that exact thing. It can be on the right or the left side of the sternum when it's placed, and your physician can figure out, the best placement for it. Sometimes women may be concerned that this device can affect, growth, especially breast tissue and things like that. This picture here shows some of the optimal placements for, so it's a comfortable position for that subcutaneous ICD, which is kind of right under the bra line and the axilla. And then the picture on the right is kind of where a man's device would sit. All right, so here's the big differences between the two. Transvenous ICD, there are several models. Like I said, I picked Medtronic to show, but there are all the companies. Boston Sci has a Transvenous, Medtronic, Biotronic, and St. Jude. So there's several different models with several different configurations. We can partner this with multiple lead configurations. So you can have an atrial lead plus a ventricular lead. You can have two ventricular leads. It can just be a single ventricular lead. So there's lots of options for the needs for the patient. You can pace with these types of devices, so that's important for some patients who need pacing. In addition, you can use anti-tachycardia pacing. So if patients have a rhythm that is amenable to a faster pace beat to get them out of it, the Transvenous ICD has this option. As I mentioned before, these devices are planted into the heart, into the veins. And if something happens to those leads, they break, they're old, we need to replace them, we do have to extract them and take them out. And that comes with its own risk. So extraction can be challenging. There in our institution, we don't do them in pediatrics very often. So we utilize our adult colleagues to help us to extract if that were to be necessary. Because like I said, there can be some more risk with that itself. There are several programming options, and that's mostly because you can have different types of leads. This is compared to the subcutaneous ICD, which has one current model. It's made by Boston Scientific. It has a large generator. As I said, it has one setting to shock how much energy you use. The Transvenous has multiple energy choices you can select. There can be a higher rate of inappropriate shocks, and that means you are getting shocked for a rhythm that doesn't need to be shocked. And so in children especially, we found that there can be a higher rate of inappropriate shock with subcutaneous ICDs. Like I said, it does not function as a pacemaker. So if you need pacing, this is probably not the device for you. There is a different implant technique. It's not in the vein, it goes in the axilla, and it's very simple programming. So it has the ability to do what it needs to do, which is shock, but again, no pacing or anything like that. All right, so the other thing that the subcutaneous ICD does require is screening before we implant it. We want to make sure that this device works properly and actually reduce the risk of inappropriate shock by screening. So this is the tool that we would use to screen for whether this device would work for you or not. In some instances, the way the EKG looks would not fit in this template here, and we would say it's not going to work for that type of patient. So all patients undergoing subcutaneous ICD has screening beforehand. In pediatrics, we often screen with exercise just because kids have higher heart rates, so we might get their heart rates up while screening before that device. So I just mentioned that you can have a risk of inappropriate shock. So how do we decrease that risk? And we're working on this very diligently. As we know, inappropriate shock can be a source of anxiety or stress for a lot of people. One, like I just mentioned, we do screening prior to implantation. It's an important part of the device implant. For children and active adults, we do screen with exercise, so at higher heart rates. And so that's something that we have adopted in pediatrics for every single patient. Also, what we'll do is after the device is implanted, about a couple of weeks later, we'll take what the device sees as the QRS pattern at a higher heart rate with exercise. So we bring them back 2 weeks after their implant, get their heart rates up, and then take that as the device template so it knows the difference between a normal rhythm and an abnormal rhythm. It is very important that patients remain compliant with their medications that are prescribed by your cardiologist. Medications like beta blockers and other antiarrhythmics can decrease your risk of these types of arrhythmia, which then can decrease your risk of needing a shock. Especially with beta blockers, it can slow down your heart rate. And so it's important, again, to use your medication so your heart rates aren't getting too high where it can confuse the device and you can have a risk of inappropriate shock. Remote monitoring is very key. We can see things that look concerning before anything were to happen. So it's very important that you keep your remote monitoring plugged in and make sure that you come in contact with it at least once a day. We can prevent a lot of things beforehand with remote monitoring. Creating and understanding a shock plan. So what to do if you were to get shocked. In our center, we ask the patient to either send a transmission or a transmission comes automatically to us via remote monitoring. This is if everything is fine, the patient has gotten a shock and woke up pretty quickly. And then we want to look at it and see if we can decide if it's appropriate or inappropriate, and then we can make adjustments either to programming or medication. There are also some features on both types of ICDs that can decrease the risk of inappropriate shock. So they're automated function. Some of them are, like lead integrity would be a word for it. In subcutaneous ICD, it's called Smart Pass, and I'll kind of talk about what that means. But these functions that are automated from the device are important for this to decrease this risk. So Smart Pass. So this is what your EKG would look like sometimes. So the top right box here where it says the Smart Pass is off. The QRS, which is the first beat here, that's narrow, compared to the T wave, which is a normal part of your heart rhythm. In this picture, you can see that it's the size is pretty similar. And with Smart Pass on, it creates a high pass filter and then actually makes the QRS stand out a little bit more from the T wave. So it's better R to T wave ratio or identification, and this decreases the risk of inappropriate shock. On remote monitoring, we can tell if this becomes disabled, and that's why it's important to make sure that you have remote monitoring. If Smart Pass becomes disabled, that means the signal has gone below 0.25 millivolts, which makes it very small, and we probably need to see you and adjust either the sensing vector or some other option. So again, remote monitoring is very important. Smart Pass was developed in the last couple of years or so. So the early iterations of these devices did not have that. And so nowadays, the newer devices, the second and third generation has Smart Pass, which again is important for discrimination between the R and T wave. So I am going to stop there. I'm happy to answer any questions, or if Julie, you want to chime in with anything. It sounds like you've had experience with both types of devices, and we can just kind of talk back and forth. Marcia, are you going to be monitoring our chat box for us?
Yes, I will. We have quite a few questions, but I think maybe Julie ought to go ahead and present, and then we can address the 14 questions that are already here.
All right. Let's go.
Great.
Go ahead. Well,
Julie. I have, my name is Julie Carpenter, and I was diagnosed with ARVC in 2019. And I initially had, my Siri is going off here. I initially had a Medtronic Transvenous defibrillator put in. And that was great as far as pacing. It paced me out of ventricular tachycardia several times in the beginning of shortly after my diagnosis. And unfortunately, over the period of about a year, I started to develop some superior vena cava symptoms. And so I had some inflammation in my superior vena cava from the lead wire. And in February, I had the device extracted and the Boston Scientific device put in, which I'm very, very happy with. So
great.
I can tell you about both of them specifically, but the subcutaneous defibrillator, I don't really notice it at all. I haven't had any inappropriate shocks. I've been very stable with it. I feel very comfortable with it, despite the fact that it cannot pace. So, yeah.
Great. Marcia, we'll take any questions.
Yeah.
Okay, here's our first question. How is it determined which patients should get the ICD or the S-ICD?
Good question. So as I said in my presentation, there's lots of factors that we take into account. One is size. So the Boston Scientific emblem, the subcutaneous ICD, is pretty big. So we don't often use them in really small children. Also, like I said, if you need pacing, just like Julie was saying, she does not need pacing. And so the subcutaneous ICD works for her just fine. The other thing is screening. So if you don't screen in for subcutaneous ICD, then that's not an option. What we do is if we have a patient that has a disease that has a condition that does not require pacing, we present both options. And we really do encourage our patients to make this decision with us. We go through, just like I did now, the differences, the pros and cons of both, and talk about it. And it's very important to have this shared medical decision-making with your doctor. It sounds like, Julie, you probably had those same types of discussions with your physician when needing to extract your transvenous. I'm assuming that the subcutaneous ICD was not out at the time that you needed your ICD in the first place, so that wasn't an option back then.
It was. I think that it was given my diagnosis and perhaps the chance that there can be progression. I think they were trying to cover all bases at the time, and given the fact the complication that I had is so rare, I think we decided that type would be the best for me at the time. Mm-hmm.
Okay. Are there any updates for batteries being rechargeable in the future?
Good question. This question, I think, comes up every time I give a talk like this. Currently, there's no technology that can make a battery rechargeable. And there are many smart people in the world, far smarter than me, that have been working on this for a very long time. And there's still not an option for a rechargeable battery. So I assume that there is no such thing at this point. Maybe we'll find something in the future, but right now there's no option. Obviously, it would be very nice if we didn't have to do extra procedures to change in and out those batteries. What they are doing is making these batteries last a lot longer. When I first started with subcutaneous ICDs, the batteries were about 5 to 8. I think we're over 10 years at this point. Transvenous ICDs can be up to 12. I think, though, the battery longevity is going to continue to change. The problem is the device is, so big, and it can only hold so much charge. So it can't last 20 and 30 years. It just would have to be a giant device. So not that I know of, but I know it's an important thing that engineers and scientists are working on, but I have not heard anything that this is a technology that's coming down the line as of yet.
So Julie, what's been your experience with your battery or just replacement of your devices?
I haven't had them long enough to test the battery, nor have they been used, which is really good because I understand, right, the more that they're activated, then the quicker it runs the battery out. So I haven't had to go down that road yet, which is good. As far as the lead extraction and the device extraction, I had that done just back in February and everything went very smoothly. I know it felt like to me it wasn't a big deal, but I do know that is a pretty serious procedure, and I'm thankful that everything went well. And I guess my advice for that is the center you go to put your device in, make sure there's somebody that can take it out.
That's a great thought there. Yeah, I think preparation is key. So these extractions can go very well most of the time. And just like Julie said, the center is key and the preparation. So having everyone lined up and ready to go with experienced people to extract, I think, is important. So
absolutely.
Okay, thank you. So how effective is pacing at preventing shocks due to VT? Under what conditions does this work?
So good question. In certain conditions, in some long QTs, we they can get into more trouble when their heart rates are slower, and they're usually on a beta blocker also, which slows down their heart rate. So in certain patients, we actually pace them from the top chamber to keep their heart rate very regular. So again, this is all diagnosis, driven. The other thing is when you have a certain type of very regular VT that isn't too fast, the ATP works very well. And so, if you have a VT that's pretty slow, like 180 beats per minute, the device can overdrive and get patients out of it. So we think very carefully about these decisions. And as Julie said, her doctors thought very seriously about which device for her to have, and Transvenous was decided for many good reasons, but then the device, didn't work out in the long run. So we really do think very seriously about these. We've also had patients that we put in a transvenous device, a subcutaneous ICD that needed to be changed out to a transvenous device because they had pacing needs and things like that. So we think hard and we make a very difficult decisions, but sometimes we have to go back and replace with a different one. And that's exactly what happened to Julie, but it can go the other way too. So subcutaneous to transvenous. So how we decide is based on the diagnosis, what we think the prognosis is, progression, as Julie said, will it get worse? The age of the patient, the longevity of the patient, the longevity of the device, whether the patient's going to grow, all those things are important deciding factors when we make these decisions. And sometimes we do have to change. That's a reality.
I was paced out of VTAC several times with the transvenous device, and it was great, as far as preventing a high voltage shock, which can be pretty traumatic. And it was very consistent. There was never any errors with that. So. And luckily I've had an ablation since and I've not needed it. So
good.
Yeah, which is great.
That's one thing I didn't mention too in my presentation of other ways to prevent inappropriate shock is other treatments like ablation and things like that. So that's an important thing to discuss with your doctor can you even just decrease the risk of these arrhythmias with other treatments like ablation and things like that. So
yeah. And when I had the VT that I was paced out of, I was on very little meds. It was early on and we were trying to figure things out. So it's a process.
That's right.
Okay. Another question. Is there a top tier gold standard brand or specific device for ICDs? I feel like I was just placed with whatever the doctor had at the hospital decided and didn't know what her options were.
Good question. So there's slightly different programming options for various devices. In my center with children, we use all devices. We use St. Jude, Boston Scientific, Medtronic, and Biotronic, and we know those different programming nuances. And so sometimes we choose a Boston Scientific transvenous device because of some option, and sometimes we choose Medtronic. So we still tailor it to our individual patient. I would not say that there's a gold standard of one to choose. I think it's a conversation that you can have with your doctor about maybe why they chose that specific device and are there other options. But I wouldn't say that, that there's one gold standard for device. It all is patient specific based on the programming needs, based on your diagnosis. So there isn't a gold standard that I know of.
Okay, thank you. How do you determine the settings of the ICD or S-ICDs?
Another good question. So we determine the settings based on, again, the disease. I feel like a broken record, but the disease itself. Also things like activity level, lifestyle, all those things are important to us, what medications patients are on. And then we look at our programming at least on a yearly basis and think to ourselves, is this the right programming for this patient with this disease at this stage? And we make little changes all the time. I mean, especially with the transvenous devices, we can change things. We can look at things. If a patient gets a shock, we will also consider, can we help this with programming? Can we change the programming to make the patient not need these shocks? So that is something that's considered, all of the time. Each time you send in a remote monitoring transmission, a physician or provider reads it and then thinks, okay, is there anything that we should do differently based on what we're seeing in the results here? And that's why, again, it's very important that patients stay compliant with their remote monitoring. This really helps us decide if we need to change anything.
Okay, what are the pros and cons of the rate response setting with regard to young, active people. As a follow-up, what's your take on doing pull-ups with a transvenous ICD?
So rate response is usually used for patients who have sinus node dysfunction. So that's another type of diagnosis that can go along with some of these. So patients who don't have a normal sinus node, meaning their heart rate doesn't go up when they exercise normally. And so that we can tell based on the transmissions plus the information that we get when you come in. It shows us a rate histogram. So we can decide if you need rate response. I wouldn't automatically program that on unless someone showed us that they have sinus node dysfunction. So I would say it's important, again, remote monitoring and for us to have you come into clinics, we can look at the rate histogram and then decide if we need to have that on. Pull-ups with a transvenous device. So when we first implant, we say, because that lead can pull itself out if you move your arm up and down. So we restrict our patients with overhead reaching for 6 weeks after implant. I would say talk with your doctor about kind of that lead placement to make sure pull-ups would be okay. But I think in most instances that it's probably okay to do pull-ups on a regular basis. But again, since I'm not seeing the X-ray in the device, I would just encourage you to talk with your doctor about the risks of a pull-up that, obviously you're using all sorts of muscles up here. And if there's specific concerns about your device, but in most instances, pull-ups should be okay.
Okay, can you talk a bit about the new ICD technology that's one lead or wireless? And this came from Rochelle.
So there's wireless pacemakers. That's fairly new, that the pacemaker is implanted into the ventricle. I have not heard about a wireless ICD as of yet, and that could be my own, I need to look up things. But wireless pacemakers, again, are implanted in the ventricle, so when you have a shock, the shock has to go from one place to another, and it creates what's called a heart sandwich. So as you saw in those pictures, the can is either up in your chest or down in your axilla, and the other end of the heart sandwich is somewhere on that lead. So then the arc of the shock goes from the can to that other spot, creating a heart sandwich that shocks your heart. So right now there are wireless, meaning no lead pacemakers that are put into the ventricle, but I am unaware of a wireless ICD.
Okay, another question from Pamela. Are leads in the heart taken out or only the defibrillator?
Like when we're removing? Mm-hmm. So I think they're probably asking, do you pull out the lead if you have to change to a subcutaneous ICD? I think it depends on the situation. I mean, Julie had her leads taken out. We had a patient that we had to change to a transvenous. We had to change to a subcutaneous. We left that lead, the transvenous lead in place because there was no reason to take it out. And because there is some risk with extraction, we decided to leave it as is. But I think maybe the question is, do you take the subcutaneous lead out if you exchange to a transvenous? And the answer would be yes, that we would take out the subcutaneous lead. That can just be pulled out. I mean, it's in a track that's outside the heart. There's no risk to taking that out when you change from one to another. So each decision is made based on the patient. Julie's came out. It was called an extraction. We have had patients that we've just left that lead in and changed to a subcutaneous or vice versa. It just depends, but you can always pull out a subcutaneous lead if you move to a transvenous, and that's something that's easy to do. But I think with an extraction, you really have to think about the risks and benefits of doing the extraction. You're on mute, Marcia.
Forgot. Thank you. How do you determine how many leads a patient needs?
Another good question. That's based on your diagnosis. So if you need pacing in the atrium, so if you need rate in the top chamber, like a patient who has heart block plus a condition that needs an ICD, we would have 2 leads. If you have kind of poor ventricular squeeze where your heart doesn't squeeze very well, sometimes we need 2 ventricular leads that helps squeeze kind of together in synchrony. So it's all based on the patient, their diagnosis. again, we can make a decision that changes in the future. So we have put in single chamber ventricular ICDs, meaning they just have one lead in the ventricle. The patient's heart rates become very slow, and then we suggest that we add an atrial lead. So Julie, did you have one or two leads when you had your transvenous device?
Just one lead.
Just one. And so we've had to make those decisions where we've had to add a third lead or a second lead in the ventricle. We've had to add an atrial lead. So it just depends on the patient. Every patient who has an ICD has to have a ventricular lead. That's just that's the way it works. But we can adjust those or add leads as we need to down the road. But we make those decisions based on the patient and their diagnosis. We try to use as minimal hardware as we can. So if you don't need 2 leads, we wouldn't put them in. If you don't need 3 leads, we wouldn't put them in. But we do try to, use the evidence that we have and work with the patient's diagnosis to decide how many leads to implant.
Great, thank you. The newer Boston Scientific treatment option of a leadless pacemaker in conjunction with the S-ICD is interesting. As a long QT patient with bradycardia, would it be a possible solution? This is from Sherry.
So you can have a subcutaneous ICD with a wireless pacemaker. We would just need to kind of work together with the setting and things like that. So we also have patients I have a specific patient who has a transvenous pacemaker, so not a wireless, plus a subcutaneous ICD. And so she needs it for pacing. And getting to her ventricle was very challenging with her anatomy. And so we put a subcutaneous ICD when she had a risk of sudden death. So we do have patients with all sorts of configurations. We again work together with how the devices look at the rhythms. And it's important that remote monitoring is part of that so we can always be catching up. So yes, you can have a pacemaker plus a subcutaneous ICD depending on your diagnosis and your needs.
All right, thank you. What happens when your heart rate goes above the pacemaker when exercising?
So when your heart rate goes above you have a minimal rate. So let's say your minimal rate is 60 beats per minute. Your sinus node is allowed to do whatever it wants. So that's what the device, so the atrial lead will see that this is a normal increase in heart rate and can tell that it is a normal fast heart rhythm, meaning sinus tachycardia when you're exercising. So the bottom chamber, if you have heart block, should follow along with it. So what happens is you become A-sensed, B-paced. So the pacemaker itself functions as the AV node, which is the node in the heart that allows the signal to go from the top chamber to the bottom chamber. So your heart rate can naturally and usually will go above that lower paced rate.
Okay. Is activating the rate response in someone with no SA node dysfunction problematic or just not helpful?
I don't think it's really problematic. If you have a normal sinus node, it's probably the rate response isn't going to do much. It's not going to need to do that. The way rate response work is it bases its kind of decision and on whether you need it or not based on how your body is moving. So and sometimes actually the respiratory rate that you have. So they have these sensors in there that allows the heart rate to go up and down and can follow, and it can tell if your body needs more rate. So there's probably no harm of having rate response on. It just isn't going to be really activated or doing much. It's because your heart rate's going to be doing its own thing.
Okay, here's a question that we could get responses from both of you. What are some restrictions with an S-ICD device? Any activities to be avoided?
So similar to a transvenous device, so with magnets like MRIs, which you can have with both of these types of devices, we just usually need to know that it's happening and maybe make some reprogramming. So that would be not really a restriction, just something you have to let your doctor know about. Like I said, right after implant, we restrict arm movement for transvenous devices. We don't routinely do that with subcutaneous ICDs. And so your activity restrictions are based on your disease itself. And let me know if you have been told otherwise, Julie, but usually the restrictions that we give you is not based on the device. It's based on what diagnosis you have and the risk of activity.
I pretty much do any activity, within my heart rate guidelines that I want to do. I have horses, I ride horses, I hike a lot, I, do strength training. I do casual bike rides now. Of course, there's the risk for falling or something, but that could happen going up the stairs or in your car. So
right.
I honestly don't think about it much when I'm doing activity. It is not really on my mind at all, which is great.
Okay, thank you. Kelly asks, any chances of a smaller device? She's a petite woman and these look huge, the S-ICDs.
Yes, so they have gotten smaller from the original iterations. The companies are always trying to make them smaller. I think we're at a point where the transvenous devices can't really be any smaller. They'll continue to work with Boston Scientific, maybe to make those smaller, or even offer a lower output shock. In kids, 80 joules is a lot, and we have discussed having a lower joule shock at 40 joules, for future devices. So these engineers, like I said, are way smarter than me and are always looking at ways to improve things. So hopefully being smaller is in the future. But I will tell you where these sit, even with a small patient, we can make it so it's not so bothersome to patients. And this is something I would talk to your doctor about.
The size is not too, I'm not giant, but I'm not teeny tiny. And it is bigger. The S-ICD is definitely bigger than the transvenous, but it's, you don't really, at least for myself, I know other people who are very, very thin, they'll notice it more. I don't notice it much at all.
Okay. I think that was our last question. I don't see any more at the moment. All right. I appreciate your time today. Thank you for being with us and educating our families about S-ICDs and ICDs. So thank you, Brynn and Julie.
Thanks, Marcia and all of SADS for inviting us. This was a lot of fun. Thanks, Julie.
Thank you very much. Thank you.
All right, bye-bye.
Bye-bye.